Okay, so we are live now. So, yeah, hello and welcome to all. This is Ankana, the assigned moderator from IGCP Group. I wholeheartedly welcome all the delegates across the country. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today. Now, I am taking this opportunity to welcome today's Master Doctor, none other than the eminent speaker, Dr. Surya Ajay Rao, ma'am. Ma'am is MBBS, MS, ENT, DAA, consultant ENT surgeon, and allergy specialist at Respiratory Research Foundation of India. Now, with the help of Dr. Surya ma'am and her wonderful insights, we will be taking a close look on today's topic, which is precision management of allergic rhinitis. Without any further delay, ma'am, I would like to hand over the session to you. Kindly proceed with your topic. Over to you.
Good evening, everyone. Thank you for giving me the opportunity to speak here. So my topic here is precision management of allergic rhinitis. So I would like to elaborate on what I want to touch today. Management of allergic rhinitis is usually we give some antihistamines or nasal sprays. So that is a generalized protocol for all the patients who come to you. So we feel we have to give an antihistamine or nasal spray. So precision medicine or personalized medicine is treating the patient rather than the disease. We understand the patient, we understand the cause, we understand at a very detailed level. So evaluate the patient much better so that you can give a more permanent solution for the allergy. So this is drug for the disease and drug for the patient. So allergic diseases are particularly suited for precision medicine because they meet therapeutic success requirements, including a non-molecular mechanism of the disease, a diagnostic tool for such a disease, and a treatment blocking the mechanism. What is allergy? So allergy is an immune response to an allergen. So what I tell my patient is, if a dust enters your nose and if you just sneeze once or twice to just take out the dust, that is not allergy. But a hypersensitivity reaction resulting in the patient sneezing 18 to 20 times, 30 times, so that triggers an allergy. So it is hypersensitivity type 1. So there are certain important terms I had to discuss. So first is sensitization, priming, atopy, and cross-reactivity. Sensitization is a process by which the immune system will produce an antibody. Once a foreign allergen enters the body, the immune system gets activated and an antibody is produced. That is the sensitization. That is on the first exposure to the allergen. And this antibody will be there lifelong, ready for any further exposure from the same allergen. So just present. So here the antibody will be IgE. So sensitization is different from clinical allergy. Sensitization can be asymptomatic sensitivity also. That means a patient has in some one day she has been exposed to the allergen. The antibodies are produced. IgE antibody is there, but the patient doesn't have any symptom. That is asymptomatic sensitivity. Only when this the sensitization, that is the IgE, causes any clinical symptoms, that will become a clinical allergy. Only when that IgE binds to the mast cells to then only it will create a clinical symptom. Then only that IgE is significant for us. I will be telling this significance of this particular point later when we discuss about the skin prick test and the other tests for allergy. So the causes of allergy can be, as all of us know, food, animals, pollens, fungus, dust mites, insects. So in the food, most common are shellfish, milk, eggs, tree nuts, soy, wheat, fish, peanuts, etc. Insects, see bumblebee and all, honeybee and all important in the foreign countries only. For us in India, mosquito, cockroach, ant and housefly are the common insects causing allergy. Pollen allergy can be seasonal allergy depending on the flowering season of the particular plant. The patient typically presents you with seasonal allergy. Some pollens which plants which cause pollens all through the year can cause perennial allergy symptoms also. So this is a pollen calendar. So this helps us to decide on which pollens can be the cause of the allergy depending on the months when the patient is affected. For example, if we take this particular cassia, suppose we are taking cassia. So April, May is the beginning of the pollen season. June to October is the peak of the pollen season, and afterwards October, November, December, January, the pollen count in the atmosphere will be very less. That's the end of the pollen season. So the patient who is allergic to particular pollen cassia will be having symptoms from June to October. So suppose we do allergy testing to a patient, we find out that a patient is sensitive to so many pollens, then we have to find out the significant pollen in this patient. In such a case, we can use the pollen calendar, correlate the skin prick test reports with the pollen calendar and his history, the months in which patient is telling the clinical symptoms, and then we can find out the significant allergen. Animals, pigeon, dog, cat, buffalo. So all these animals, epithelia causes allergy. Fungus. So presentations, allergy can cause, there are three major presentations. One is skin allergy. Another one is nasal allergy causing sneezing, anterior rhinorrhea, posterior rhinorrhea, sinusitis, itching and watering of the eyes, headache, nasal congestion, nose block, etc. This is the typical allergic salute. Patients with nasal allergy can have other manifestations also, like bronchitis and skin allergy symptoms. Allergic bronchitis affects the lungs, causing cough, sputum production, thick sputum, which doesn't come out, causing dry cough, breathing difficulty, noise breathing, and restriction in work capacity. Another very dangerous presentation of allergy is anaphylaxis. We see it very rarely. So the patient gets abdominal pain, itchy, rashes, swelling, tongue gets edematous, the lips get edematous, the airway gets edematous, causing breathing difficulty, stridor, shortness of breath, causing headache, giddiness, anxiety. So all these symptoms are the symptoms of anaphylaxis. So this is the mechanism of the type 1 hypersensitivity of allergy. So say there is a sensitization phase and the effector phase. So when an allergen comes in contact with a dendritic cell, so these are the watchman cells, which is present in the nasal mucosa, in the skin, everywhere. Wherever there is a first contact with the allergen, dendritic watchman cells will be there. So this gets presented and Th2 cells gets activated, which produces interleukin 4 and 13. Th2 will give signal to the IL4 and 13 will give signal to the B cells to produce IgE to the particular allergen. So this is the sensitization phase. So on first contact with a particular allergen, for example, house dust mite, everybody will be having serum IgE to the house dust mite. Now, if the the significant step in allergy is serum IgE getting bound to the mast cell. So on second exposure, on the second contact, only if the serum IgE is bound to the mast cell, then this IgE can take up the allergen and cause an allergic reaction. through a decoupling reaction, causing the release of histamine, tryptase, leukotrienes, prostaglandins, etc., causing acute symptoms of allergy like anaphylaxis, asthma, whatever we have discussed. So this is the significance of serum IgE and bound IgE. So most of the blood tests which detect allergy, the allergy panels, they detect only the serum IgE. So there are chances of getting false positive test. Just the presence of serum IgE does not indicate allergy. It indicates only the sensitization. If we do a skin prick test, the mast cells of the skin only react to the allergen. So we are more sure of the test. False positives are very less. Next important thing is atopic march. So why it is important to treat allergy at an early stage? So as the number of years increases, maybe in birth, the child may have only eczema. The patient, the doctor will, the parents will go to multiple doctors. They will give some antihistamines. Then once the child gets exposed to food after 1 year, then the child will be labeled as food allergy. Again, antihistamines will be given. Then in 3 to 7 years, when the child goes to a daycare or a school, he will start getting a leaky nose. Again, the child will be given antihistamines. Once a child starts playing a lot, then the parents will finally realize the child has asthma. So this allergic march is the development of more and more allergic symptoms as the age progresses. So this needs to be stopped. Early diagnosis of allergy. If we find out the allergy, cause of the allergy, stop the exposure or give immunotherapy at an earlier stage, we can stop the allergic march and stop the other symptoms of allergy. Another important thing is hygiene hypothesis. So there are naive T cells. So a child in a village who is playing outside in the soil, getting exposure to a lot of viruses and bacteria, the Th1, that is the one which is active against the infections, that will get more developed. So the Th2 activity will be less. So the child will be non-atopic. But as our city life has increased our hygiene, the child has lesser and lesser exposure to viruses and bacteria. The Th1 activity becomes less. Th2 activity increases because his child is exposed to pollens and mites indoors. So in such case, the child gets more chances of becoming a atopic or a potential allergic child. So this is the hygiene hypothesis. More exposure to viruses and bacteria, that is normal playing. The child should go to daycare. The child should play outside. Sorry. That will cause, that is good for the child. So what is the disease management? So I told in precision medicine, we don't manage the disease, we manage the patient. So disease management, what we usually do, we give oral antihistamines, we give intranasal corticosteroids, intranasal antihistamines, oral corticosteroids in severe cases, nasal decongestants, and in certain cases, we go for surgery like FES, septoplasty or turbinate procedures. In asthma also, similar things like inhaled corticosteroids, mucolytics, and antihistamines and steroids, oral corticosteroids are given. So this is the area guidelines for management of allergic rhinitis. Here allergic rhinitis is divided into mild intermittent, moderate or severe intermittent, mild persistent, and moderate or severe persistent. So according to the guidelines, mild intermittent and moderate severe intermittent, we give medical management. And after that, if it is more, then this patient is a candidate for skin prick test, allergen identification, and immunotherapy. So what are the pharmacotherapy? What are the medicines we can use? Sodium chromoglycate glycate that has my effect on the sneezing, discharge, and blockade, mild effect only. Usually we don't use it much. Oral antihistamines has good effect on the itching and sneezing and nasal discharge. But one problem with oral antihistamine is it will dry up the secretions in the nose, causing blockage in the nose due to the thick secretions and can cause sinusitis also. So usually for patients with just nasal allergy, I usually avoid giving oral antihistamines. We manage with nasal sprays. Ipratropium bromide for the nose is not available in India, but it reduces the discharge. It has more of a vasomotor effect. Topical decongestants we don't use for allergic rhinitis because it reduces only the blockage by decongesting the nose, reducing the size of the turbinates. Topical corticosteroids are very important in the management of allergic rhinitis. It very nicely reduces almost all the symptoms of allergic rhinitis like sneezing, discharge, and blockage. Oral corticosteroids, it's better than topical corticosteroids, but due to the systemic side effects, we use it only in severe cases. Anti-leukotrienes can also be given. It reduces the discharge blockage. So I have seen many prescriptions where a patient will be really allergic and the prescription will be for 5 days, 10 days and all. So here we have to keep in mind something called minimal persistent inflammation. So when a patient comes to you, the patient is having an allergen exposure and symptoms will be almost at the peak. We should give medicines to the patient for as long as in such a way that the symptoms come down below the threshold level. So you should give long-term treatment for the patients with allergic diseases. If you give just 10 days medicines, the symptoms does come down, but always that minimal persistent inflammation will be there, causing the more and more recurrence. So this is called minimal persistent inflammation. The patient is always in a state of hypersensitivity, and the patient will be having a threshold level over which if the symptoms hypersensitivity increases, the symptoms start showing up. So if you give a short course of nasal sprays or whatever medicine we are giving, we are just bringing the patient below the threshold level. We should also bring it below the level of the minimal persistent inflammation. For example, certain patients with house dust mite allergy or pollen allergy, any perennial allergy which is always around, the patient will always be having a minimal persistent inflammation. And when this particular patient is exposed to cold or dust or any other irritant, soon he will jump the threshold level, causing the symptoms. Patient will recognize the cold or the dust as the cause of the allergy, but real cause of allergy is the real cause of the minimal persistent inflammation. That can be the dust mite or whatever is positive in the skin prick test. It can be food allergy also. So this is the precision allergy management. So that is precise allergy diagnosis, patient education and allergen avoidance, symptomatic treatment with medications, causative treatment with allergen immunotherapy, and prevent new sensitization and stop allergy progression. So if you think from the patient's aspect, surgery cannot treat allergy since it is a systemic disease. There are patients who come with a recurrence after test within 1 or 2 months also. Patients are on continuous dependence on antihistamines, which has its own side effects like causing headaches, irritability. Even though there are non-sedatives antihistamines, still they make them feel drowsy. Patients are asked to avoid a wide range of substances which affects the quality of life. Most of the patients want to know which substance they are allergic to. From a doctor's aspect, always we have a patient who is not satisfied with our treatment, and patients look at you for a permanent solution. They keep on changing the doctors. And atopic march, it is our duty to stop atopic march by treating eczema or allergic rhinitis in children properly to stop the progression to asthma. So first we have to be sure whether it is really allergy or not. But you have to take a proper history. We have to spend time with the patient, assess the severity, talk to the patient regarding the duration, regarding their environment, find out what the patient is allergic to, do the test which is required for the allergen identification, find out whether that allergen is significant by taking a second history, decide whether the allergen is avoidable or not, and whether the patient is fit for further treatment. These are all the questions we'll be answering in the next slides. So history taking is very important. Occupation, whether there is a lot of dust exposure, whether a patient is working in a textile shop, whether there can be a lot of house dust mites and cotton dust. What is the mode of travel? If the patient is traveling in bike, there is a lot of pollen exposure. Whether the patient is taking a suburban train where there can be a lot of pollen exposure. Duration of illness, whether there is a change of environment, recent change of environment. Patient has shifted to the 5th floor of a building recently, and there are a lot of pigeons around, and from that time there has been an allergic rhinitis. So the pigeons can be a cause. Seasonal variations in case of pollen allergy. Diurnal variations, when more symptoms at night, that is when the patient is having a house dust mite allergy. When the patient is on the bed, sleeping on the bed, the patient will be having a exposure to the house dust mite and allergy. Outdoor or indoor, any fungal allergy can be indoor, pollen allergy can be outdoor. So history gives a lot of inputs in allergy. Old or new house, apartment or flat, pets, animals or birds, types of furnitures like carpets and cotton mattresses, any new food consumption or any new drugs taken. Common investigations, we do serum total IgE. Many patients, they usually come with a serum IgE report, but even with patients with normal serum IgE, we have found out allergies. So that is not a reliable test, and even patients with parasitic infections can have high IgE without allergy. CBC, sinus X-ray, CT-PNS to evaluate the sinuses, X-ray chest, PFT to evaluate the lungs. Now coming to the main point, skin prick test. So after taking the first history, we have to convince the patient, tell them the importance of allergen identification, explain everything to the patient. We have to decide on which allergen is our target. We have to mark the areas in the hand or back wherever we are going to do the test. Apply the drops, give small pricks with the small subcutaneous pricks with a small lancet, and wait for the reaction for 15 minutes. So this test will detect the bound IgE. That is what I told. Mast cell bound IgEs are tested in skin prick test. So we apply a drop of allergen on the skin, give a small prick with a lancet, and wait for the skin reaction. So this is the skin prick test. Here we measure the wheal rather than the erythema. We don't measure the erythema, we measure the wheal. Histamine is taken as a positive control and saline is a negative control. And the reaction, the allergen reaction should be 3 millimeters more than the saline. Saline should be less than 3 millimeters because saline is used to rule out pressure urticaria. Histamine is done because some patients will would have taken any antihistamines and not relieved the history to you. We are not supposed to do the allergen skin prick test for the 72 hours. For the previous 72 hours, patients should not have taken antihistamines or any benzodiazepine. Such medicines should not have been taken by the patient. So this is that's a positive control. Pseudopores develop when there is a uncontrolled allergy, excessive allergy. The patient can get pseudopores. So immediate wheal and flare is due to the neurogenic mediators. Whatever we get in the 5 to 30 minutes is the mast cell degranulation. That is the allergic reaction. So any reaction before 5 minutes to 30 minutes, we don't consider it as allergy. So the late phase reaction also, we don't consider it. So it can be done in the middle, according to the sensitivity. Middle and upper back is more sensitive, and lower back, antecubital fossa and ulnar side of arm. We usually do it in this aspect of the hand because that's the most easily accessible area for us. There should be a 2 centimeter gap between the allergens. The skin should be clear. There should not be any active eczema, and the skin should not bleed on pricking. It should just be a subcutaneous prick. This is the intradermal method for allergy testing. Nowadays, very less number of people do it. Here, individual intradermal pricks should be given for each allergen causing a bleb. So there are more chances of side effects in this intradermal test than the subcutaneous test. So this is the blood test, radioallergosorbent test. Here, serum IgE is detected. So patient serum containing the serum IgE antibodies is added to a fixed allergen. After washing away the unbound serum IgEs, enzyme labeled anti-IgE antibodies are added. Then again it is washed. Unbound anti-IgE antibodies are washed away, and the signal from the bound antibodies is measured, bound to the IgE. So here serum IgE is tested. So there are a lot of false positives. So this is the comparison between the skin prick test and specific IgE. So skin prick test, we test bound IgE. Specific IgE test, that is the Fediatope or immunocapital, it will detect the free IgE. Skin prick test is limited number of allergens, and specific IgE we can do it any number of allergens provided the patient is ready to pay. Skin prick test specificity is high. IgE specific, the Fediatope, the sensitivity is high, so it can be used as a screening test. In skin prick test, the patient can see the reaction. So the complaints of the patient to our treatment will be better. And the reaction can be seen within 1.5 hours. So we can give a report within 1.5 hours. But in the other case, we have to wait for 48 hours, and it is very costly also. In some, where will you do specific IgEs? In case patients where they cannot stop the medicines, such some patients with epilepsy, depression, even allergic patients who cannot stop the medicine for 3 days, then we can go for serum IgE as a second option. So now that we have a report in hand, we have to take a second history, determine the significant allergen, determine whether it is avoidable or not. If it is an avoidable allergen, we don't go for immunotherapy. We just give avoidance measures. Suppose a patient is allergic to milk. We don't go for immunotherapy for milk because it is an easily avoidable thing. We ask them to avoid it. But if the patient is allergic to house dust mites or pollens, which is really there around in the surrounding of the patient, you cannot ask them not to inhale that pollen or the house dust mite. We have to give desensitization treatment. So that desensitization treatment is the allergen immunotherapy. So this is the only disease modifying treatment. All the other treatments for allergy is just for disease control. So it alters the immune reaction to allergy by deviating the Th2 pathway to Th1 pathway. That is IgE to regulatory IgG4. It also reduces the new sensitization, and it stops atopic march. So this is the again the hypersensitivity type 1 hypersensitivity pathway. So when we give slit or skit, so sublingual immunotherapy or subcutaneous immunotherapy, IL-10 is produced, which will cause blocking, which will increase the production of T regulatory cells, which will cause blocking, produce IgG4. IgG4 is the blocking antibody. That means it will block the blocking of IgE cross-linking by IgG4. IgG4 will go and bind to the IgE, blocking their activity. There is no space for the IgE to go and bind to the mast cell. So IgG4 is a blocking antibody. And here in the it will also reduce the block the activation of the Th2 cells. So the IL-4, 5 and all is not produced. Interferon and are not produced. So this is sublingual immunotherapy and subcutaneous immunotherapy. Duration is around 3 years. Dosage can be weekly or twice a week. Sublingual can be taken at home. Subcutaneous should be taken under medical supervision because it can cause other side effects. Allergic reactions can happen. So if you ask me whether it is sublingual or subcutaneous is more efficient than sublingual. But if you ask a patient to get injections twice a week just for the allergic symptoms, most of our patients will not agree, and they'll have to go to office and so many commitments will be there. They will not agree to come to your office twice a week. So the patients will go without taking any permanent measures. So practically sublingual is more feasible, but the efficacy is lesser than subcutaneous. So there are certain indications for immunotherapy. It should be a specific IgE proven. SPT is preferred always. SPT should be positive for that allergen. After second history, we should be sure that the allergen is significant. There should be constant exposure. Just because skin prick test is negative, we won't give immunotherapy. And we should be sure that the allergen cannot be avoided. Constant dependence on medications, uncontrolled with medications. Patient wants permanent cure, young patients, and it reduces recurrence after surgery. Usually, we don't give it in severe asthma, significant cardiovascular disease. If the patient is taking beta blockers, any anaphylaxis, we will not be able to use adrenaline. Polysensitization, if there is lot of allergen sensitization, it is not good to use immunotherapy for just one allergen. So it's not going to stop the symptoms. Less than 6 years, we don't give, and patient complaints is very, very important. If the patient is not ready to follow the module for 3 years, then there's no point in starting it. So this is the graph of quality of life improvement after 3-year course of sublingual immunotherapy in patients with house dust mite and grass pollen induced allergic rhinitis. So the red is after sublingual immunotherapy and blue is before sublingual immunotherapy. So the symptoms are fairly reduced. So most of the cases, the immunotherapy has worked in reducing the asthma medication scores in this meta-analysis. So the take-home message is allergy, it reduces the quality of life of our patient. We can offer them tests to find out the cause of the allergy. We should spend time with the patient, and detailed history taking is important. Allergen immunotherapy helps to reduce the dependence on medications and improve the quality of life. Proper avoidance measures should be used. That's it. Thank you.
Thank you so much, ma'am, for this comprehensive talk. And ma'am, the presentation was so much informative. We have received, ma'am, few questions from our participating doctors. With all your due permission, can I put them across?
Yeah.
Okay. So the first question we have received, that is, what are the common comorbidities associated with allergic rhinitis, and how should doctor approach their management in conjunction with rhinitis treatment?
Most of the patients with allergic rhinitis, I take a sinus X-ray and see whether it has there is a sinusitis. So if the patient is has sinusitis, we should treat them for the sinusitis by giving nasal sprays and saline nasal washes. Before the sinuses, the mucus collection in the sinus gets infected and patient comes to you with a acute sinusitis, it is better to prevent it. Another thing is any patient with allergic rhinitis, now it is the concept of unified airway. So any patient is allergic rhinitis, there can be a bronchial hyperactivity. So we should take an X-ray of the chest, make them undergo a PFT and evaluate the um, lungs also. So if there is any bronchitis, we should treat the bronchitis also.
Okay, we are moving to the next question, that is, what are effective strategies for promoting patient adherence to prescribed treatments for allergic rhinitis?
Patient adherence.
Adherence, yes.
Okay. So the first thing is the rapport you develop with the patient. So most of them would have gone to minimum 10 doctors before coming to you. Everybody would have written Monte Kelsey or any I'm sorry, I took the name, any antihistamine or leukotrienes or nasal spray, any all these treatments they would have taken. So we should understand the patient. We should assure them that, and there are patients who have been trained, who have been really they are very worried that some doctors have told them that there is no cure for allergy, all these medicines are only for control. So they think that they are having some disease which cannot be cured. So we should reassure the patient that once we find out the cause of the allergy, the patient is there is a chance of cure. I have taken asthma patients off inhalers by giving immunotherapy to them. There are patients. So we should give them reassurance. We should spend time. I take around 1.5 to 2 hours with a patient before I decide on an allergen for immunotherapy. So we should really go into their lives, see there can be typical histories like I shifted to an apartment 5 years back. I came to Chennai 5 years back. I started the problem started. So all these things we have to decide on the allergen. We have to decide on the immunotherapy. We have to take a second history. So all these things, there will be minute things. For example, I had a patient. He drives to drop her daughter to school through one particular road around a park where there are a lot of peltophorum flowers. That patient was highly sensitive to peltophorum on skin prick test. So if I have to get the history of that patient driving to drop the kid through that road, I have to spend that much time with the patient. Then I have to convince the patient that it is due to that. Then he just changed the route of his morning dropping the kid and he is fine now. So all these things are very important. Talking to the patient, giving them assurance, I think that's the key.
Okay, coming to the next question, that is, are there any promising pharmacogenomic approaches to allergic rhinitis management on the horizon?
Yeah, that is what we discuss now, immunotherapy.
Okay, moving to the next question, that is, how can precision medicine approaches help optimize treatment outcomes for allergic rhinitis?
Yeah, that's what we cannot give just any antihistamine. Every doctor will be having a set of drugs for allergic rhinitis. If the allergic rhinitis patient comes to me, I will be giving this. So that I don't think that is the way to go forward with allergic rhinitis, because these people are the real sufferers. We cannot provide us a good prognosis with surgery also. So we should find out the real cause of the allergy, treat the patient rather than the disease. That is what I emphasize throughout the presentation.
Okay, the last question we are taking for this session, that is, what are the latest developments in immunotherapy for allergic rhinitis and how can doctors integrate this into their treatment strategies?
A lot of developments. There are sublingual immunotherapy, subcutaneous immunotherapy. immunotherapy tablets have also come in. I don't know if in India, I don't think it has started. So that patients can easily take them nowadays. So
Okay.
yeah,
Thank you
even
so
immunotherapy patches, they are starting to bring it in foreign countries.
oh, Thank you so much, ma'am, for answering all the queries of our doctors. And I would also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, ma'am, for your valuable time and for being with us at our platform and sharing such valuable insights with us.
Thank
So,
you.
ma'am, with all your permission, can we close the session right now?
Yeah, sure. Thank you.
Okay, ma'am. Thank you, ma'am. Good night.